Good afternoon, everyone. Thank you so much for your interest in this joint webinar. Certainly we know that partner services, especially as it relates to data sharing and data use, has been a hot topic for many of our jurisdictions as you start to incorporate new software and systems that will better support program collaboration in your partner service efforts, especially as it relates to stopping the spread of disease and making appropriate client referrals. We have several speakers today that will share their experiences and provide a background of partner services, also discuss the current landscape of partner services, and discuss some future directions for partner services. And hopefully at the end of the call we'll have some good ideas and some good lessons learned about how to move forward for those of us who are making those changes at this time. With that, I'd like to introduce today's presenters. First, we will hear from Rebecca Jordan-Yale, who is the Program Manager of the Client-Based Prevention Services Program at the Colorado Department of Public Health and Environment. After Rebecca, we will hear from Bernard Gilliard, who is the DIS and Partner Services Manager at the South Carolina Department of Health and Environmental Control. And last and certainly not least, we have Jeff Hitt, Manager of HIV, STD Prevention and Intervention at the Texas Department of State Health Services. So with no further delay, I will hand it over to Rebecca. And Rebecca, please remember to *7 to unmute your line.
Hi, thanks Dana. Can you guys hear me?
We can.
Great. Thank you so much for asking Colorado to participate. Very exciting to share our experience. So, as long as there we go. Oops. I guess there's a little delay here. Okay, so just to give you some background, Colorado has been an integrated STI-HIV program from the very beginning of the HIV/AIDS epidemic. In 1982, the first case of AIDS was reported to the Department of Health. In August of 1985, so before we actually had statutes, the Board of Health adopted rules requiring the named reporting of positive HIV antibody tests or AIDS diagnosis to the State Health Department. And in 1985, a disease intervention specialist, we used to be called venereal disease investigators, actually conducted the first interview on a person who was reported to be HIV infected, actually was an AIDS case. And they conducted this interview just as they would any other a syphilis interview, for example. In June of 1987, Colorado was the first state to legislatively mandate named reporting of persons testing HIV antibody positive. Our HIV statutes actually mirror our STD statutes. However, there are far greater protections specific to the limited ability and to share information with really persons external to the public health process. In 1993, our Board of Health adopted rules regarding CD4 and viral load reporting, and if anyone's curious about what those were, you can always email me and ask. I'll spare you the details, but what's important that is in 2010, we clarified those rules to include all viral loads. So we originally had a viral load cutoff, and what we found was that that was really limiting some of our surveillance abilities, our surveillance information, by not also having those persons who were viral load undetectable. And that'll make more sense as I kind of go through how it is that we are integrated. So integration, the perks. Certainly it is the only environment that I have worked in, so I think it's pretty spiffy, but our section is under one roof. We're on the same secured floor, and it includes our prevention coordination, contract monitoring, fiscal, counseling and testing, community planning, and the direct client services of partner services, linkage to care, comprehensive risk counseling and services, surveillance, and care and treatment, and that's where our ADAP program and the Ryan White administered services live in our care and treatment program. We use the same data systems, PRISM, EHARS, CD4 viral load. Soon we will have ARIES for entering in information specific to care and treatment services, and ADAP enrollment database, which is connected with Ramsell. So our services are, we like to believe, comprehensive for the client. Certainly only staff who have need to know are able to access any given database for the specific needs related to their job. And more perks. So we have full client history in PRISM and soon in ARIES. So when someone is identified as being co-infected, it is readily apparent to us because all that information is in PRISM, and the DIS then interview what we refer to as relapse cases, and that's someone who's infected with HIV and then is reported as being infected with a subsequent STI. So then all the additional interventions to address the client's needs are actually here and available seamlessly to the client. So just to give you an example of that, a client will come in and be given their confirmatory HIV positive test results by a disease intervention specialist. They then do the partner services interview and then bring in our linkage to care coordinator, and she talks through with them some of their concerns, thoughts around accessing care, can begin to complete ADAP enrollment information if it appears the person would be eligible. Then next we can bring in a comprehensive risk counseling and services provider that we have on staff, who then can check in with the client about any additional psychosocial needs, concerns, given the information they just received. So literally there have been countless numbers of times just within the last couple months where it has happened for the client in that manner. In one instance, the client, in order to be able to enroll in ADAP, needed a copy of his birth certificate. And because that is on our first floor of our health department, we were able to send the client down and facilitate them getting their birth certificate. Then they could give us a copy, and boom, they're ready to go. So that's been really, really a very positive thing about our continued efforts to move our integration forward, specific to how the client interacts with the services we provide. So our activities are integrated from primary prevention through virologic suppression, and I have a flow chart that kind of provides a visual for that a couple slides away. So data drives our activities here in our program. The registry staff within the surveillance program receives the lab reports for CT, GC, syphilis, and after doing some data entry into PRISM, they then are able to forward that to the supervisor of the Client-Based Prevention Services Program, who then initiates the work, if there's any work there to be initiated, to the disease intervention specialist. Reports of positive HIV tests are assigned to the case ascertainment unit of the surveillance program. They do their case ascertainment work, and then the case is forwarded for assignment to the disease intervention specialist. Our DIS actually creates a feedback loop then to complete any demographic information, risk information, test history, and any other pertinent information specific to the case that might be of epi significance, either to the surveillance program or into the case investigation work. All of that's fed back into PRISM and then is useful on a number of different levels. And so just because Partner Services lives in the program that I manage, I have to brag a little bit that partners generated from interviews are obviously most at risk and resulted in an overall seropositivity of 13.5% for the DIS in 2011. So we feel like we're getting to the people that we need to, and again, that using our existing data, it really helps us to know where we're going and who we need to talk to. More examples of data driving activities. Our surveillance program, the data there really determines where target areas for HIV testing and the focus of our limited STI resources. When we look at overlaying maps, as we have done, of demographics from census information with disease morbidity, it really helps to give us clarity around the implications of the social determinants of health and really how that looks for Colorado. Certainly most of our disease is in the Denver metropolitan area, but it's been very helpful and insightful for us to be able to look at these maps simultaneously. Data supports collaboration across divisions and programs within all of public health, and some examples of that would be partnering with other divisions within the department that focus on youth and being able to work out some collaborative projects with them, collaborating across the Department of Education and community organizations. The data also supports our efforts to partner with external agencies and to really push for services in areas most impacted. When you can show someone a map that has mapped out, we'll just go with index cases for HIV, that can really communicate a great deal about really where the services need to be and who needs to be able to have enhanced access to them. And so another way in which the data drives our activities is that our surveillance program can actually do a match with the ADAP enrollment database. And in that way, we're able to ensure that everyone who's enrolled in ADAP actually is known to be HIV infected. And that's certainly a priority for us to make sure that we're really clear on who's receiving ADAP. We don't have a waiting list in Colorado. If you're curious why, you can email me and I can give you the contact information for Bob Bongiovanni, who is our Care and Treatment Program Manager, because he's done an excellent job of managing things so that doesn't happen. But this is one of the ways that data can really help to drive what we're doing and who we're offering it to. CD4 viral load history, our linkage to care coordinator actually is able to get a report of persons who have not had a CD4 viral load in the last year, and that initiates active linkage to care follow-up. CD4 and viral load levels and prescription renewal activity can be accessed and compared, and is, to determine who might need assistance staying engaged in care. So it really initiates those retention and care activities. So this next slide is a bit busy, but it gives you an idea of what our continuum of services looks like from primary prevention, which would be under pre-infection, all the way through viral suppression. That increasingly is our goal, that everyone who is HIV infected knows they're HIV infected, and that we are able to support them in achieving viral suppression. So you can see we have it broken down across specific services, behavioral health services, and the service providers that would deliver those, sort of our red flag system. So really, what are those things that we know are warning signs for someone that they're about to drop out of care or potentially engage in behaviors that could put others at risk. And then the HHS, so Health and Human Services indicators, are just listed there across the bottom. And so just some challenges about our integration process. Even an integrated program can have silos. We've always been integrated, but services, our activities have not been as seamless as they are increasingly today. The program managers and our new section chief, Melanie Matson, work very diligently to continue to move forward in truly an integrated program across all of our services. It does require increased communication to avoid duplication and stepping on each other. No other way to say that. The ripple effect is really important. What one staff person does with any given provider can affect everyone else's future relationship. And I put with that client or partner because providers being partners, community-based organizations being partners, And you just never know who the next person is that's going to need to talk to or negotiate a relationship with that person. And it's all the way from the DIS all the way through our section chief. Innovations and shifts in staffing or in shifts in focus really involve all the managers working together and talking as we increasingly move as one and move forward together. And here is my contact information and the information for Anita Watkins. So please don't hesitate to email us or contact us if you have any questions. And certainly any additional partner service specific questions, I can also connect you with our partner services unit supervisor, Yesenia Mendez. So thanks so much for your time.
Thanks a lot, Rebecca. And next we're going to hear from Bernard in South Carolina. Bernard, remember that's *7 to unmute your line.
Can you hear me now?
Yes, we can hear you. Thanks.
Okay. All right. Thanks for the opportunity to share South Carolina's process with the group. Next slide. In South Carolina, we're organized at the state level. However, South Carolina is organized into 8 public health regions, and each region kind of functions or operates autonomously, meaning that there's a formulary designed or used to calculate the percentage of federally and state acquired funds to be dispersed to each region to perform partner services activities, and STD and HIV follow-up as well. And once that's done, then the regions receive the money. The DIS staff, they're regionally managed, owned, and we're all state employees, but they answer primarily first to the regions. And those jurisdictions have primary responsibility for delivering the deliverables that the program at the centralized state level writes or requires and requests of them. Next slide.
Bernard, if you would just speak up a little bit. We're having a bit of a hard time hearing you. And
okay.
For anyone else, there's a bit of background noise. If you would please mute your line.
Okay. Is that better? All right.
That's great. Thanks.
South Carolina, like other states, began HIV partner services on top of already doing STD services, particularly syphilis and some STDs in the way of PPNG and things like that. So the South Carolina activities are completely from day one integrated, meaning that the duties and responsibilities of staff are to perform partner services activities across diseases. We don't have HIV-only DIS or STD-only DIS. And also, when we look at the performance of an individual region or an individual DIS, we hold everybody to the same standards, but we have performance measures that we measure everybody kind of unilaterally on. Now, there are some differences based on geography and based on morbidity and staff experience and time in job and those kinds of things that kind of get factored in a little bit later down the road. But the programmatic responsibilities are programmatic measures number 28, and there are 12 for syphilis, 8 for HIV, and 8 for what we call previously positive HIV persons who continue to put others at risk by acquiring a new STD or being named by somebody who has a newly acquired STD. Next slide. Some of the partner services inner workings. The case report data is reported via ELR, fax, traditional mail, direct entry into an electronic surveillance system that many providers in South Carolina have access to enter their data, kind of the electronic version of what used to be the old disease report card that folk used to mail in that would be keyed in by the public health authority, in this case DHEC, and that would start the initiation process or the reporting process. And then we have interstate partner services follow-up case management. That's persons identified in South Carolina needing notification or needing management regarding a positive test or something of that nature, usually those are called in via phone. There are still some amount of faxing where we get, from some jurisdictions, faxed information. And also we have data transmission across the regions. A case may be interviewed in one region and partners identified in another region, so that other regions provide that information to do local follow-up of the individuals. Next slide. In South Carolina, we use a version of the CDC Partner Services interview record to collect our Partner Services information, and that's a paper version. Currently, that's the only capacity that we have, although we are going electronic some with a PDF fillable document to do some of this electronically in an electronic folder system in a secured server spot where only DIS can hit it, and it's transmitted back and forth that way. Also, one of the other interesting things about South Carolina is the DIS staff do not locally enter their case information. It's all sent to the centralized surveillance area at the state level here in Columbia for data entry by dedicated data entry staff. The local DIS staff have view rights to any of the information. They also, in some cases, have access to disposition STDs in the way of chlamydia and gonorrhea, the low priority STDs. We have two systems. We have the STD MIS database system, a CDC-built system that we put the STDs in, gonorrhea, chlamydia, syphilis, and we have an EpiInfo database system that we put HIV in. So currently, even though all the information is documented on a single paper interview record, somebody who's co-infected or somebody who has HIV gets the same interview record, when it comes to data entry staff actually put them in two different systems, but staff has access to both the systems. So it's a little bit difficult and tricky sometimes to readily identify co-infected individuals without tapping multiple database systems. Next slide. Service delivery. As I said earlier, each DIS performs STD and or HIV partner services, follow-up activities. Additional services by DIS are identified, and as the client's willing to accept, appropriate referrals or linkages are initiated to the identified service providers. With some clients, positives and or high-risk individuals in particular, professional services providers relationship occur, meaning that the person may be referred to social work for individualized additional counseling and risk reduction behavior and management. They may be referred to other services, to everything from voc rehab to job services to alcohol and drug. Also, there is a collaborative effort between the clinical side of most of our facilities, the DHEC health departments scattered throughout the state in each of the 46 counties, that when the clinical side cannot get in touch with a person for a positive lab or to get them back in for whatever services, a referral is usually initiated to the DIS, and it's usually initiated either in paper fashion, written, or a phone call. Now, in South Carolina, we have about 38 DIS. They're not in every county, and they vary by region, but each nurse and each DIS has the responsibility of all of the citizenry in their area. So they work the whole, even though they're headquartered in one location, they work the whole area. And there is prioritization based on syphilis and HIV, newly diagnosed syphilis and newly diagnosed HIV being the highest priority. Next slide.
And Bernard, I'm sorry, if you can just speak up a little bit more. We still have some folks having a hard time hearing you.
Okay, and I apologize. Let me do this. I took it off a speakerphone. Is that better? The collaborative efforts in South Carolina.
I think it's actually harder to hear you now.
Okay, we'll put it back on speaker.
That's good there. Thanks.
Okay. The collaborative effort on the ground The status is continuously updated and discussed among regional or local program co-responsible teams. As needed or indicated in the following may be initiated. All of our DIS staff are tasked with, on an annual basis, identifying an amount of providers or percentage of providers that either generate most of the morbidity for their area or most of the problematic reporting for their area, missing variables on reports. And they're tasked with a provider visit to that facility to discuss with that provider or that facility the need for complete data, the need for timely reporting, and they also do that with lab. As we run reports and have information available on a monthly basis, we also watch for trends, increases in general or increases in a particular population. And as we see those, then that's an opportunity to rev up or increase the screening, and that's internal by the DIS actually doing community screening, or we partner with several community-based organizations throughout the state that are kind of strategically placed in the areas that have highest morbidities, where they're mobilized, and either in conjunction with the DIS, they target the particular population or area or wherever the increase is coming from. And target's probably a bad word, but they focus on that population to increase testing to identify cases quickly and more efficiently. We also do increased education of stakeholders and community providers, and that's part of the visit, as well as sometimes PSAs are initiated. Sometimes there are organized, for lack of a better word, town hall meetings where there's a community gathering of a blended group of folk, everybody from the providers to the consumers, who can get together and be informed, have knowledge of, discuss, get information about how and where they can get individual information or services as they need to. We also have a process where health alerts or an HAN report can be constructed and disseminated to a particular area as we see increases in a morbidity or situation. And that is HAN requires some approval from management at the state level, but it's easily done. We've initiated some of these things because over time we've seen situations where the DIS would identify something, and if it wasn't passed on to somebody else to track or follow up, then it may fall through the crack. And an ideal example of that would be congenital syphilis. The DIS interviews a mother who's pregnant. Well, obviously that mother's going to deliver, and then the follow-up of that baby needs to be done, irregardless of when the mother was treated, because the baby's probably going to have a positive cord blood. Well, all that communication happens at the local level, and there is a congenital syphilis nurse case manager who is assigned to a pregnant female, and in the case of syphilis. And at delivery, the congenital syphilis cases report form is filled out, but there's communication back and forth between the DIS and the congenital syphilis nurse case manager to assure that this child is having follow-up either at a pediatrician or back at the health department, these required RPRs. And it's a similar situation for perinatal exposure to HIV, a HIV-positive woman. There's a perinatal HIV nurse program manager that follows up on that as well. Next slide, please. We also have many contractual arrangements with community-based organizations, AIDS service organizations, and infectious disease clinicians, to include Ryan White Corps providers and such throughout the state. The State Public Health Authority, DHEC here, issues out issues out a percentage of money to other providers to additionally provide services. And many reasons exist for that. One of the reasons that's been cited recently with the increase in MSM syphilis or MSM co-infection or MSM HIV is that oftentimes they say, oftentimes an MSM person would say they would choose not to come to the health department because of cultural competency or cultural sensitivity and issues like that, but they are more agreeable or more willing to go to other agencies. So this is a mechanism where they can choose their medical service home, albeit temporary, but they can choose a home that fits with them, so they're more likely to comply with, they're more likely to engage in, and get the intended outcome, screening, testing, management, that kind of stuff. We also have monthly case report numbers generated. We have quarterly partner services staff meetings with at least the regional supervisors of the DIS staff across the state. Oftentimes they bring a lead or some additional person. We also have semi-annual meetings with a lot of our contractual partners. Some of those, in fact, are quarterly. And we also have an annual state conference. And these are all venues to provide and share incidence data, best practices, interventions, future objectives, and things of that nature. Next slide. When the DIS staff and the partner services component collects its data and does its work, all of that fits into and feeds into what we design or what we set forth on an annual basis as far as the CSPS grant and our involvement with CDC, as well as Healthy People in South Carolina. There's a Healthy People 2010, Healthy People 2015, Healthy People 2020 that has certain benchmarks, objectives, and measures in it that we should try to target and hit the target on. So as the years roll on or on an annual basis, we all get together and kind of write objectives, think about things. And in South Carolina, the STD HIV division has partner services in it, which is composed of DIS, but it also has a surveillance area that deals more with the HIV part, and it has Ryan White and ADAP and all of those programs, as well as CRCS. And we have also an expanded testing initiative in South Carolina where we have individuals on staff who are assigned to hospitals that go do screening in emergency departments. Basically, people who are present at emergency departments, they're offered stat screening for HIV. Some of it, the hospital staff does the actual screening. Some of it, our staff does the actual screening. But all of that, I'm saying all of that to say that when we write grants and when we provide annual reports or interim progress reports, we're considerate across the genre as far as DHAP, the Division of STD HIV Prevention, and DSTDP in writing objectives, in dealing with individuals who could have both infections or could have one infection and may graduate to acquire the other infection. So there's a lot of sharing of best practices. There's a lot of sharing of data trends. There's a lot of sharing of linkage to care ideas and what works and what doesn't work, as well as working on ways to impact the next or the rising population or target group for our area. Next slide. And this is the acknowledgement slide here, so there's only one probably left, but just a couple of more comments about some challenges and lessons learned. One of the challenges that we face here in South Carolina is the paper environment for partner services. Like I mentioned earlier, we have a paper interview record that the DI staff receive their assignment electronically, but they mail through courier mail or paper mail, snail mail, back into a centralized area for data entry. That remains kind of a challenge for us, but we have invested in, and next year we will spend that time building on a comprehensive partner services database, a Maven-type database that will allow more electronic transmission, more data. Well, it will be designed for data entry at the local level by DIS staff of their case activities. So part of that challenge will be solved. Coordinating with collaborators in funding data, service matching, and accountability can sometimes be a challenge given the volume of subcontracts. And if a person has a subcontract with syphilis elimination, a subcontract for HIV, who gets the numbers when somebody gets tested for both? We don't want to count people multiple times for the same thing. And then again, meshing DSTDP and DHAP definitions, expectations, and outcomes. Some of the lessons we've learned is plan, then revisit the plan, adjust the plan. Also to communicate progress, the good, the not so good, the bad stuff, and be prepared to problem solve is another lesson we've learned. Thank you for your attention. And the next slide, that's my contact information. Feel free to contact me if you need additional information.
Thanks so much, Bernard. And last but not least, we have Jeff Hitt from Texas. Again, Jeff, it's *7 to unmute your line.
Okay, I think I'm unmuted.
You certainly are.
Great. Can everyone hear me?
Yes.
Great. So thanks for having me on this webinar. I've got my colleague Sydney Minnerly here with me, and she might pipe in here if I forget to cover something adequately. And I'll also try to address Siga's very good question, I think, as we march through this. I want to give you a little bit of how Texas is set up and how we operate. We have always sort of had in mind that we use HIV and STD reporting data to trigger public health follow-up. And that's been a program value for a very long time. Also, of course, we do surveillance and monitoring, planning and resource allocation, and then evaluation, both of the surveillance system itself, of our prevention and services programs, which I'll talk about a little bit more at the end, and then also the HIV and actually the STD-related healthcare system, so looking at unmet need, participation in care, confirming treatment, particularly for syphilis. So that's sort of the basics of how we use data. Let me get comfortable with advancing slides here. And if you want, everybody raise your hand. And if you're tired of hearing from fully integrated HIV STD programs. I apologize because we are also what I would call fully integrated. So we have HIV and STD surveillance and prevention and control programs from the state perspective and the local perspective are really essentially completely integrated. We do have a decentralized system in Texas, so local health departments are the reporting authority. And then we also have regional health departments where there really isn't a health authority for counties or at least STD services. So we cover that through regional health departments as well. We don't typically do disease intervention out of the central office. So we do that in a pinch when programs are really suffering and they need some extra support. But we are really administrators, evaluators, planners at central office. So we have authorized and secure sharing of HIV reporting data between HIV and STD programs. And so trying to address Siga's question that surveillance, so HIV surveillance information actually gets uploaded into STD MIS, and that is how DIS cut a record to start an investigation. That gets uploaded. So a lot of our data now on HIV is coming through electronic lab reports, and it actually gets comes centrally first, gets matched and researched, and then cut to STD MIS, put into STD MIS to cut a record. And similarly, HIV surveillance people across the state, both centrally and in the local health departments and the regional health departments, have access to STD MIS, so they can look up information around risk, things like that. They can use DIS notes to help further the completion of surveillance records. We have one set of confidentiality rules and security rules for HIV, STD, and TB. So we are all one. We all work for the same people. We all work for the same health department. We're all under the same rules. So we all have access to the same information because it's necessary for our jobs. And that's, I think, how we do that. I talked a little bit about laboratory reporting. A lot of our information is now coming in through electronic labs. We have had named reporting of HIV since '99, and all labs, all viral loads and CD4s became reportable in 2010, regardless of the values. So we're getting a huge information flow from that as it's been implemented. I do want to mention about our decentralization. It's not on our slides or anything, that we currently have 19 installations of STD MIS across the state. We are in the process of centralization of STD MIS, and then we'll be moving to a Maven-based program eventually. That centralization process has been like a cathedral building. We'll spend generations, it feels like, to complete that beautiful building. So this is a diagram that looks at our flow, lab reports, mostly for lab reports coming in. There's an eligibility determination about, is this appropriate for follow-up? And then it's a little bit bifurcated in terms of priorities for public health follow-up and surveillance investigation for HIV and AIDS. But you can see, like, our priorities for public health follow-up are syphilis reactors. Those get researched more directly into STD MIS. And then the HIV data goes through EHARs, but then eventually gets uploaded into STD MIS. You see our priorities are syphilis, and new HIV cases. We work virtually all the cases. There's a little bit of mismatch in terms of what's a new diagnosis in EHARs versus what's considered a new diagnosis by a DIS once it gets investigated and locally. I'll talk about mismatch in data and definitions a little bit, but essentially we cut a record on every syphilis case that's diagnosed in Texas and every new HIV case. We also do follow-up on known HIV cases, of course, who are contacts or diagnosed with a new STD, pregnant, and then we are pursuing fairly aggressively, but still mostly in planning stages, about how we initiate on people not in care. HIV not engaged in care, and that's a little bit more complicated because we want to make sure that we're not cutting a lot of records to DIS that are not going to be fruitful. We want to look more broadly than we are able in a moment, so we have to look back and use some older data to look across our care reporting systems. We get access to Medicaid data, but that's usually once a year. We have some access to private insurance data. We use our ADAP data to really get as clear a picture as we can of unmet need for HIV medical care. We want to start using that to initiate cases. And we have started some provider-initiated follow-up for people who fall out of care, but that's still sort of testing it out in a few areas. So interoperability, I love that word because it's so hard to say. But it's something of an issue with EHARs and STD MIS. You know, we have cases in one database and not in the other, and that's actually, I mean, it's a fairly recent discovery to really be able to investigate that and understand why that's happening. Some of it is due to some differences in how we define a new HIV case. Oh, I'm sorry, I'm jumping ahead a little bit to some of the not investigated cases. But we're at the stage right now where we're doing ad hoc matches between STD MIS and HARS. We really haven't systematized completely how we can pull pertinent data from STD MIS and import it into HARS. Done some testing of that, but it's really going to depend on centralization right now, and it may depend on moving to Maven, because right now some of that information is only contained in case notes in STD MIS, and we have had surveillance staff here have gone through reams of case notes, basically, because it can be years and years worth of case notes on a person sometimes, to sort of get the details and see if there's something that needs to be updated in EHARS. I think it's really a problem. We talk about data streams, and this is really a stream that tends to flow one direction, and it actually needs some channels that feed back. So we need better feedback mechanisms. As we move towards a Maven-based system, it will integrate HIV surveillance, STD surveillance, all of our public health follow-up, and it will also include TB. And that's not just to house it under one architecture, but to have that information, pertinent information on any person in there should be viewable by any surveillance or disease investigator, surveillance staff or disease investigator. So that's some of our challenges that we're still working towards. I'd say that we have a pretty good system considering sort of the challenges we have with STD MIS. And we'll talk about a little bit of those later. So just an example of some of the things that we're investigating with our data are sort of QA and looking for why is this happening. We see some cases that are not initiated for public health follow-up or not interviewed, and it's looking like about 20% of the HIV cases. Oh, and I don't have a slide on it, sorry. It's just in notes. About a quarter of that looks like it's probably a missed opportunity. 17% of that is a client refusal, and then about 35% are unable to locate. So, it's not just one reason why these things happen, and I think that's always a frustrating thing to try to tease out what's really contributing to this issue. Well, it's a whole number of issues. Again, going back to that case definition of a new case, DIS may investigate and find something about the case that really does indicate that it's a previous diagnosis, but it can't really be reported, or like it was never reported. It's from another state, but they didn't have HIV reporting at the time, and they've had zero viral loads, undetectable viral loads for a very long time, and so it's just now showing up, and so that ends up new. So those are some of the things that we're challenged with in terms of just QAing the data. So I don't want to belabor this point, but just the point of the next few slides is really to say that we look at a lot of data. I wish I had actually taken a screenshot of the spreadsheet that looks at our partner services outcomes. Part of my frustration is that it's on a spreadsheet, that we don't extract it as directly as I would like from data analysis. But again, I'll talk about that a little bit more. But you can see where we get the interviewed cases, the number of partners. We really shoot for a 2.0 partner index and find a lot of previous positives. Of course, we get a 7% new diagnosis. That's actually dropped over the past few years. It's been, it was a 9% in 2010, I think, and about 10% in 2008 and 2007. So we have some things to look into. So Lisa, we'll have to address your question about determine your index, because I'm not sure which index you're talking about, but we'll pick it up. So this is looking at our early syphilis cases, and you can see the interviews assigned, which is really about, it's virtually all the cases. I mean, if you look at the morbidity, it's going to look a little different. Just that's really about artifacts in the data, but we interviewed 96% of the cases, got to most of them in a very timely manner. And you can see all of the things that we're looking at, the case with partners initiated, re-interviews, clusters, disease intervention index. I'm not sure if I can even explain it correctly. It's a preventive treatment of negative partners of syphilis. So that's looking at like 60%. How did we arrive at 2 as our target for? That is, it predates me. We decided that was a programmatic goal. And it's really an interesting question, I think, about what's appropriate, because the appropriate number of partners for any one case is however many partners they had, of course. As we average that out over a program, we're looking for 2.0. So 2 partners per case. I think that's set as a relatively aggressive target, something that's a little bit aspirational for our programs. We don't meet it all the time. We have to kind of stretch for it, and so that's part of how it gets set. The pitfalls of that, and I was going to talk about this later, but I think it's a good time to talk about. I think the pitfalls of looking at as much data as we do and working with our partners is you can get a sort of program myopia around some of these things. So one example with the partner index being 2 is a situation we had where we found a number of records were being closed on syphilis cases, and they had 2 partners, but they hadn't found anybody who was really infected. They hadn't found an infected partner, or at least one that fit the time frame for infection. So they were closing cases because, we got the appropriate number of partners, but they weren't getting the appropriate number of partners relative to that particular case. And that is an important distinction to make when we look at what are our program outcomes, what are individual DIS outcomes on cases, or individual case outcomes, what are program outcomes, and then also what are population outcomes. So I'll talk about that a little bit more. And so here's some more data that we look at in terms of the efficiency and impact of our partner services. When we look at partners closed, obviously we're going to find some people who were previously treated. How many get examined? How many are not examined? And then, of course, we want to know some details about that. How quickly were they examined? What's happening with the not examined cases? So you can see some of the outcomes here. And again, most of them unable to locate. So that's a big priority for our frontline supervisors, our first-line supervisors. Is this person really unable? Are we really unable to locate this person? And let's make sure we've tried every avenue, things like that. So So before I really address this slide and future directions, I wanted to talk about our use of data, and I think that the partner services data is actually quite complex in terms of multiple records. A person's in there multiple times, named as a partner, even with a disease that's more static like HIV and not episodic like multiple STD infections, there still can be in there multiple times named as a partner over and over, things like that. So how we analyze this stuff is a little tricky, and we've been hampered by our ability to extract data out of STD MIS, especially from these 19 different installations, and create one analysis file where we could actually correct some of the data and address some of our larger questions about population impact as well as sort of the programmatic effectiveness. I think our first-line supervisors, the majority of the data use that they do is really about an individual case focus. It's about QAing that case investigation. It's also about managing workload on the DIS, and it's about priority setting. Making sure that we are focusing on the priority cases. I forgot to mention that we have about 85 active, fully trained DIS working in a number of different local and regional health departments across the state. Our program managers have not a lot of time and sometimes not as much data expertise to really look at the population effects of our work. They are really managing their staff, trying to balance workload. Again, we have a pretty high turnover with DIS, and they are to some extent focused on our 20 program indicators. A lot of the things that you saw across those slides are some of our program indicators. I think there's a danger in having too many program indicators, and I think we fall into that a little bit. We sort of collapse our data sometimes to grade programs rather than really look at the data to explore opportunities for program improvement and for population impact. So those are some of the things that we struggle with our data. In answer to the question about who provides partner services, it's DIS. They're employed by local public health and by the state in our regional offices. We pretty much they're full-time disease investigation staff. They investigate primarily syphilis and HIV. There's a fair amount of cross-training with surveillance staff and DIS, so there's a little back and forth between that. But that is pretty much all their responsibility. So the future direction, I already talked about our plans for moving to Maven to manage all of this data. We'll be really piping EHAR's data into it. We're still going to, because of the document-based nature of EHARs, I think we struggled with how we would build Maven to accommodate that, but we are working on a way to easily and quickly push that data into Maven, and then all of our STD morbidity data, our TB morbidity, and all of our partner services, our public health follow-up efforts would all be contained in those data. And then we're on the HIV prevention and care services programmatic side, we're really moving to one framework under ARIES to contain those data, and hope to be getting faster and faster about our ability to match those data and take action on them. So one big issue, I think, is that harmonizing that case definition for HIV and for public health follow-up is particularly important. And then finally, really, how we do population-based evaluation versus programmatic evaluation. And I think that we're deep into the process evaluation of our program, and I think we do a pretty good job we do a great job at producing that data. We struggle sometimes to make the best use of those data to improve our partner services programs, but that's sort of simply the time and attention, the analysis capability to manage those data. So as we increase that, we'll get better and better. You know, one of the things that I think that we don't look at is our population-based outcomes. We often diminish the denominator to examine each process step as we move from cases assigned to cases interviewed to partners found, and then you've always got to look back at the total morbidity and understand what your overall impact, the overall impact of your program looks like. You need to do both, and you know, it's so hard to add more at this point, but we need to. For example, I think source spread analysis is a great indicator of your population impact of partner services for syphilis. I mean, you should have a source spread on every case, basically. You should have an infected person related to every case, but it's a little more complicated than that. I mean, we have a field for that in STD MIS, but making sure that we're all using it correctly and defining that appropriately is a challenge. And then we can look at it through a different method and do some data calculation to find it, but it really is complicated because we can have, you know, two people both infected who name each other, and so there's an infected case related to each one of those cases, but we know we're missing one more case. If there's not another infected case on that, then we're missing at least one more. There should always be a chain. So that I think is a really elegant number to reflect your efforts, but it's quite difficult for us to calculate with the setup that we have right now and extracting those data. That is pretty much sums up how I think we're using the data to the best of our ability and where we need to go in terms of improving our understanding of our partner services efforts and how they inform a larger effort. And here's my contact information if you would like to talk about it further. And now I'll go ahead and advance the slide to the question and answer period.
Thanks, Jeff, and thanks to all of our presenters for sharing your expertise. We already have a few questions that have come in through the chat, so I'm going to ask those first. And folks, if you'd like to ask a question on the phone, you can press *7 to unmute your line. Jeff, the first one I have here, I believe, is for you, and someone would like to know what percentage of those interviewed named one or more partners.
Let me see. I have to dig through a spreadsheet to tell you that. If I looked at, say, new HIV, 73% of the cases named a partner. That's 73% of the 88% who were interviewed. So that's another example of like what's your denominator and what's your overall, what's your overall population impact versus what's your programmatic efficiency.
Great. And another question for you, Jeff, is whether or not you have Internet partner services, and if so, if you could talk a bit about your findings.
Well, I think Internet partner services is it's a thing, but it's not really a thing. I think that we use different Internet modalities to pursue partners, definitely. But more and more we treat it just like any other communication message. So I don't know that use of email, is use of email even an Internet-based partner service? Yeah, those are it's pretty much built into our work. In terms of using some of the dating sites, we have a number of programs who are still, despite many, many efforts, still not allowed to access sites that have sexually explicit information. So, but we actually have workarounds for that. We actually work with the City of Houston very well, and it works better than I would have thought. If one program can't use it, they send it to Houston. Houston does the initial contact and then redirects them back to the DIS. I don't have numbers at my fingertips about the productivity of that in particular. Again, we initiate on all fronts. So if we have a phone number and an email, why not do both?
And this is Sydney with Jeff here in Texas, and Jeff's right. We don't have any way of actually calculating the outcomes of the Internet contacts because we really don't have any dispositions that are different from any other outcomes. So an H is an H is an H, whether you've driven out to their house or made phone calls or sent emails or try to locate them on a sex website. So it's pretty much all the same at this point. I mean, we had good outcomes initially and when we were measuring it, but at this point we do not have any dispositions that differentiate.
Thank you. And another quick question here is, several people would like to know how many DIS you have in your state.
We have about 85. That's sort of active, fully trained. There's a fair amount of churn. I think there's probably 90-something positions.
Great. And this question is for Jeff or for Rebecca. If you would talk a bit more about ARIES and how it may relate or interact with MAVEN and PRISM.
This is Rebecca, and I can't speak to MAVEN because I'm not so familiar with that, but the plan is that because disease reports are entered into PRISM, the ideal is, and what we're working towards, is that the demographic information that's entered in for the client will, when the disease report is appropriate, automatically populate ARIES so that there won't be the need for double entry. And so that really has been the initial starting point that we have discussed how they will work together. I will add, in Colorado, we have six disease intervention specialists in the metro area, and one in each of the outlying areas who do DIS work at about 60%.
In Texas, we collect all of our sort of Ryan White related HIV care services information in ARIES. We are in process of building mostly HIV testing, community-based testing efforts into that, but also we'll eventually build some other prevention efforts. Our ADAP data are currently in a different system, but we're building the module now to contain that in ARIES. So pretty much all of our HIV prevention and care data will all be in that set. I mean, I think the way we use those data now is really extracting files from HARS, from looking at ELR and STD MIS and ARIES data, matching it all up. For a long time, we've gotten data from Medicaid and from some data from private insurers that we're able to match. We're able to match to HARS, to the HIV surveillance, and be able to characterize unmet need. That becomes more and more important as we look at initiating on people who aren't in care. So that's a sort of a supplement to how we will research people's participation in care, is look beyond just like evidence of a CD4, but also look at, are they, do they have evidence of a provider visit? Do they have evidence of a prescription? But we're just not getting the lab, so it'll contribute to that. The change in reporting for ELR, though, actually, for reporting of viral loads, has really changed the landscape in terms of those data, so that ELR data is very important, and we're starting to move that data into both ARIES and into EHARS. Obviously, it moves into EHARS, but we also move it into STD MIS, and we move it in, and especially move it into ARIES.
Thanks, Jeff. The presenters may have noticed that we're getting a lot of questions through the chat, which is wonderful. We'll try to make sure they're all addressed, but feel free to also unmute your line and ask a question if it is not addressed. We're just being overwhelmed with questions here. This next one goes for Rebecca, and would like to know, how do you prioritize existing HIV cases with subsequent STD diagnosis for partner services? Are your numbers such that prioritization is not necessary?
Hi. People are sort of like kind of laughing. No, that's the quandary that we're in right now, actually, because we need more than 6 DIS in the metro area, because the bulk of the cases that staff are currently working are what we refer to as quote-unquote relapse cases. Those are persons who are known to be HIV infected who are co-infected with a subsequent sexually transmitted infection. The bulk of our syphilis is in MSM, and of the early cases of syphilis, and I'm sorry I don't have that number right off, but the early syphilis cases that we had, I can say, in 2011, over 50%, almost 60% were in MSM who were co-infected. So that is the bulk of our work. Really, our DIS are working, they're working early syphilis cases, relapse cases, and persons newly identified as being HIV infected. And they're currently incredibly overwhelmed. And it's really the relapse casework that is contributing to the overwhelming workload. And so we've got some things in place to try to work on that. For example, we're not going to be talking to persons who are newly infected with, or not newly infected, but who are known to be infected with HIV and are newly reported as having gonorrhea or chlamydia. If it's their first subsequent STI, we're not even going to talk to them. We're actually going to send them a correspondence offering them partner services and linkage to care and CRCS, but we're not going to assign them for cases, and that for case investigation. And that really only, in a 6-month period of time, knocks out about 60 cases. So, 6 in a month when our DIS are working, 70 or so cases a month. It's something, but it's not a lot.
Thanks, Rebecca. And this next question is for any of you. You all spoke about an integrated model of STIs and HIV. Do you find that there is any distinction when it is just an HIV case compared to an STI and HIV combo case?
I don't really think so. I mean, there are certainly, like on the ground, there are going to be some different aspects to how you handle the case, and that linkage to care element is is, you know, HIV is a chronic infectious disease versus an episodic infectious disease. So that's a little bit more complicated. I think we really, you know, we've been using a more episodic-based model, and we're shifting the way we think about. I mean, we have been shifting the way we think about and do that work somewhat with HIV cases. But in the broad scope of things, no, they're not really much of a different approach.
It's Bernard. I kind of agree with Jeff. Although sometimes the prevention with positives comes back in down the road because it's a chronic disease, and oftentimes, you know, people at initial diagnosis or upon interview will say, okay, that's it, I'm never having sex again. And that's true for a week, a month, or a couple of days, and then they get back in the game. So, you know, you may run across that person again. So we make a little bit more of an effort to establish a longer-term relationship or build a little bit more rapport in with that individual, because we're probably going to contact them again. And we've had one or two regions that actually, on people who are diagnosed, once or twice a year, they make an effort to follow up or check in with them via phone call or a field visit to their home or somewhere to just see how they're doing, if they're in and out of care, and, you know, kind of a quick back-of-the-envelope re-interview of them about additional partners.
Hi, this is Yas Simpson. Can you hear me?
Yes, we can.
Hi, I'm Yas Simpson from Chicago, and I'm in HIV surveillance. And I wanted to know, you all really are very much integrated, but we here have HIV field workers, and then we separate our STI field workers. What advice would you give us to how we could better integrate, because we're having to do two steps to try to do the partner services? I'm going to go back on mute so you can talk.
First thing, I guess, go back and look and see if there are laws that require you to be separated. And if there are not laws that require you to be separated, kind of put out some feelers to see why that's continuing, because as more and more people become co-infected or as resources kind of dry up, we don't need, or it's not a best practice to have two different people interview the same person for two different diseases that are very similar, and some of the contacts, the partners, the players are the same. It's kind of redundant to some degree.
This is Rebecca, and I agree with Bernard. Check your statutes, check your state laws first, and make sure there's not a problem, and then pilot it. Just give it a try. Assign to a more senior DIS a case where someone is co-infected, and let it roll, and you know, track it and see what happens. I mean, the skills are the same. It does help to have more experience when you're working with relapse cases. I can say in Colorado, in terms of how we treat things differently, as in a co-infection versus a new positive, they are different for us. Much like the other jurisdictions that spoke, we're focusing on linkage to care for sure, initiating linkage to care follow-up actively if we have reason to believe that the person's not linked in care. And we're big on disclosure in the state of Colorado. That is, disclosure of your HIV status prior to having sex or engaging in needle-sharing activity. We do not have criminal statutes here in Colorado. We kind of like it that way. We do, however, have a process internal to the health department where we meet as a group once a week and review all of those relapse cases and talk about the best public health intervention for that person. And that involves our two comprehensive risk counseling and services providers. And and they're both they're both licensed professional counselors. And we have contracts with two external counselors that we will refer people to who may have some additional issues. So we do address it differently, even at the DIS level. They're really trying to motivate folks to share to share information regarding someone who can confirm that they disclosed their HIV status before sex, even if that means just have someone call me and let me know. So we do look at it a little differently because we see those persons who are continuing to get subsequent sexually transmitted infections as playing a role, perhaps, in driving the infection.
This is Jeff. I have to say, Rebecca, that sounds so awesome to be. I think with the size of Texas, we get swallowed up in administering and evaluating the program, and we're not quite as able to operate on that level in terms of focus. But I love the sound of that. And that's what we have to promote to some of our partners. I think in terms of approaching integration, it's really hard to give advice when you've sort of done it from the beginning. But I think that obviously Bernard hit it on the button that you've got to make sure that your laws are in place to allow you to share those data. But if they are, then it's really a policy issue within your organization, and that's about consensus building around what is appropriate use of the data, and the fact that again we all work for you all work for the same health department. You need access to the same data. You're doing essentially the same intervention. There are slight differences, but those don't have to be. Those don't need to be magnified to the point of such specialization. So I don't know how to give you any more direct advice than that. I mean, I think you can, a particular step might be unifying confidentiality rules and security rules around your data, and having one set of policy, one policy set around that might be a step towards a more integrated program and more integrated use of the data.
And I'll just add to what was just said, because we operate under a security and confidentiality policy that meets HIV surveillance level requirements. So we go to the highest level, if you will, of security and confidentiality, and that for us is the HIV guidance that we get. So I think that's a good point in terms of how you might integrate your policies as an initial step.
I know we're getting close to time here. I have one more question that I am going to read. If there are any other burning questions from the audience, feel free to speak up now before I ask that. We can stay on the line for a few extra minutes. I don't know about the presenters' schedules, if any of you have to jump off.
I can be here for a little while longer.
Okay. Well, this next question is for any of you. We'd like to know if you have memorandums of agreement with any major private clinicians to allow for automatic partner services for cases in which the provider reports to surveillance without the DIS first contact from the provider.
So we do not in Texas. They're required to report. A disease investigation, a surveillance investigation may often start with contacting a provider, and disease investigation could also. There are a number of providers who insist that we don't contact their patients, and they insist that they will work with them around notification. That doesn't mean, though, that we don't necessarily cut a field record on those persons and do an investigation. We do not need MOAs to do our public health duty. So, no.
This is Bernard in South Carolina. Public health law in South Carolina says that the public health authority, which is the Department of Health, shall conduct investigations. So once a provider or a laboratory submits a report of a confirmed case or a physician or provider diagnosis, then we're automatically able to follow up and engage that client. Now, we take the roundabout approach in almost all cases. If it's outside of the Department of Health's clinics and providers in earnest with private providers, we contact them to query or get some data first. Verify the person's name, verify the status, see if the provider is aware of the status, because sometimes the lab submits it to both of us and we get it before the provider actually is aware of it. So we make sure the provider is aware of the outcome. We check with the provider about, has the client been told? And then if the client's been told in the case of HIV, then we inform the provider that we intend to follow up with the person to provide partner services. Now, if the person objects, the provider objects, we still try to sell them a little bit on the benefit of our doing it, but we will allow them to do it, and we will make a contract with them to do it and provide some additional data to us in the area of contacts and some essence about the conversation and the partner services that the provider will do. Sometimes in the few providers who initially chose to do that, when they realize all that they have to do, they kind of back off and say, well, let me talk to the person, and yeah, give me a day or two, and you can have at them, or call me back in a day or two. I'm pretty sure I can convince them that it's okay. They will cooperate with you when you contact them. So again, it's a matter of public law, but we do go by the provider first unless it's a case where there's like a plasma center or an outside lab that's the only collector in the essence of life insurance or something like that, where there's really no provider to contact.
I think, Bernard, you make a good point, though, that law in Texas really reserves partner notification as a health authority function. So it's the function of the state and local health departments. Right. And so we do not have community-based organizations doing any notification or anything like that. We have a few that might elicit partners to help with investigation, but they don't do notification. So it's a function. It's as a public health function. No, we don't make MOUs or MOAs with providers.
Yeah. Now, sometimes we'll try to embed DIS in providers to try to present as a unified or a seamless process from partner services to provider care kind of situations.
Right. Which, I mean, you work with providers to sell it as support for their clients rather than policing their clients.
Thank you. I know we've run a few minutes over. Does anyone have a question that they would like to ask as a last question? I know there are a few that have not been addressed in the chat, and we invite you to follow up with me or with the presenters directly. But in the interest of time, I just want to make sure that nobody has a burning question that's not being asked. Okay, well, if not, thank you again so much to our presenters and to all of our participants. My contact information is up on the slide, and these presentations will be available on both the NASDAD and NCSC website in the next few days. Thanks a lot, everybody. Take care.
All right, thank you.
Thank you. Please stand by.